This bronchoscopy session is moderated by Dr. Sunil Deshmukh sir, the panelist, Dr. Divya Prabhat, Dr. Shyam Somani sir. Yes, sir, please. Dr. Ashok Purohit sir, Dr. R. Ramesh, Dr. Prashant Hippargikar, Dr. Amol Sulakhe, Dr. Sanjay Bhagat, Dr. Parmanand Bhakt. This session will be chaired by Dr. Pushkar Lele sir, Dr. Chaitali Zamre, Dr. Rajendra Akul. The chairpersons are requested to please sit on the first row.
As per the instructions received from Dr. Prasad, as we are running short of time, so with permission from organizers, may I start the session? So good afternoon, good evening to all. So I'm feeling like if an incoming flight is late, so outgoing flight will be late. So I'm really sorry for that. So with this, I'll start the session on bronchoscopy. Actually, I really feel blessed to have such doyens in the bronchoscopy in Maharashtra, and it's really a houseful panel in real sense as well as houseful audience. So I am really blessed to have these great people and these great people here. So to start with, actually, what I want to say is, with this discussion, I expect that the young and budding ENT surgeons should definitely get lured by this noble and novel field of bronchoscopy to save more and more lives of those unfortunate children who may succumb to death if they are not treated early and within time. Pointer next. Actually, at the outset only, I wish to thank the organizers and especially Dr. Prasad for giving me a chance to conduct this session on bronchoscopy. So I feel this is a session, panel discussion of lifesavers and life lovers in real sense. So as we know, in ENT there are very few emergencies. So this is one of those few emergencies where we can save lives of those children. So coming to straightway to our panel first slide, I request Dr. Amol Sulakhe to just why tracheobronchial foreign bodies are common among children. Dr. Amol.
As we know, most of our 80% of the foreign bodies in tracheobronchial tree in children, we see in between the age group of 6 months to 3 years of age. The main causes for they are basically all deciduous teeth. They erupt at the age of 6 months to 3 years of age. There is again easy distractibility. There is oral way of exploration. Children lacks posterior dentition. And again, they are having very high respiratory rate. Adenoids are enlarged from 6 months through 3 years of age. Their respiratory rate is very high. So I think these are some of the causes.
Very
because
good.
whatever you put it,
Yes.
they will try to put it in mouth. And again, it is very high chance of going this in the
Yes, very good.
tracheobronchial.
Dr. Divya sir, you were looked at. Dr. Sanjay?
Nothing, sir.
Okay.
One thing,
Dr. Shyam.
little bit lack of coordination is there between swallowing habit and in children.
I think anything which comes in the way of a child, he tries to grab and put into the mouth. I think that is
Behavior,
what Dr. Amol.
High respiratory rate, they
yes.
could not even
Yes, that
hold
is-
the breath for longer duration of time.
So, yes, sir. Shyam sir?
Nowadays, the children have a habit of looking at the mobile and then eating. The parents only, they give the mobile to the child.
Valid point, sir.
And this is one of the cause we can think, because he is distracted in the mobile and then swallowing also. So that can be one more additional new factor.
Yes, sir.
Rhinitis, postnasal discharge, and a crying child with improper swallowing reflex, which is not yet well developed, is considered to be one of the
Yes.
class A reasons.
Yes.
Parents are forcibly feeding the children.
Yes, sir. Yes. We'll,
They are crying and
Yes.
they are
Yes, sir.
forcibly fed.
yes, 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 yes.
They cannot identify the objects very well. So many of the plastic material, metal materials, they doesn't know it very well. So the which is not edible, that goes stuck up into the tracheobronchial tree.
Yes. Okay. Okay. We'll go to the next point. Why? This is a very important question. Why there is a delay in the diagnosis? So I want to have opinion of panel. Why there is a delay? There are a lot of.
The delay in the diagnosis is because the child is smarter than the parents and the caretakers.
Yes.
There is no history available as far as a foreign body aspiration is concerned. With time, the symptoms that you get keep on changing. In the first week, they are treated as acute laryngotracheobronchitis. After a week to a month, they are treated as a pneumonia. After a month to 3 months, they are treated as asthma. From 6 months onwards, they are treated as tuberculosis. After 1 year, they are treated as multi-drug resistant tuberculosis. So the diagnosis keeps on changing with time, and that hinders with the diagnosis. And the other point to compound this is that the doctors also keep on changing.
Yes, that is very true, sir. Okay.
Covered everything.
Sir, almost, so history is many not time there, symptoms are not there, ignorance, then traditional ways, some people put the finger and then they try to remove, overlooking by earlier this is covered, and unavailability of experts as well as general practitioners' related attitude as told by, yes, Shyam sir.
There's one more point. The child goes in a silent phase, asymptomatic phase. Once the episode of inhalation and bouts of cough is there, that episode is forgotten. The foreign body lodges in a peripheral area and maybe 3 to 5 to 7 days of asymptomatic period is there. Yes. So that is one more cause for delay.
Yes, that is a classical.
Lack of awareness by pediatricians and ENT surgeons.
Yes.
Suspect, and suspect.
Yes.
Because most of the patients now, they reach first pediatricians.
Yes. They are the primary referrals for ENT.
Unless pediatricians suspect foreign bodies, he will not.
So, bronchoscopies depend on pediatricians' referral many times. That is the story. Yes. We'll go to the next. This point actually can be a difference of opinion. Which side of the foreign bodies you feel to be common, left, right, and there are different reasons. Just comments, any specific comments in your practice?
Sir, in my series,
yes.
I found almost equal incidence.
Okay,
because, the reason for finding it so, despite the belief, is that usually it is not the gravity, it is the inhalational force.
Yes.
That is the reason why the foreign body enters the tracheobronchial tree.
Yes.
So,
yes.
In my series, almost equal percentage of the right or left.
Yes. Anybody one differs? Yes. So almost, yes, almost equal, yes. We'll go to the next slide. So this is again very important. Why we are not comfortable in dealing with a foreign body. So this is so Dr. Sanjay, go today.
Because we are taught in residency that it is very difficult procedure. This is the main problem
Correct.
which I believe.
That's
because I started my bronchoscopy in my private setup itself.
Great.
And I find bronchoscopy is easier than esophagoscopy.
Yes.
Most of us may be agreeing about this point. This is very easiest procedure which I feel, bronchoscopy, than esophagoscopy you can say. So this is the problem is with during the residency learning is the problem.
Yes.
It's a lack of proper team, I think so.
We remember wrong things. That is the reason why we are not comfortable. We remember laryngeal foreign bodies, we remember subglottic foreign bodies, and we remember those havoc-creating tracheal foreign bodies.
Right.
We forget about what the differentiation whenever we talk about foreign body airways.
Yes.
It is not a single thing. It is a laryngeal foreign body,
Yes.
tracheal foreign body,
And
bronchial foreign
yes.
body. Bronchial foreign bodies are by far cool. There should be no problem with.
Yes. They are relatively
Depends
safer, you can
when,
say.
When these patients, they come to you, if they are delayed and sometimes they are airway compromised,
Yes.
they are hypoxic, then it becomes a little
Yes.
bigger issue. The
Yes.
first fresh foreign body first attempt
Yes.
is a very easiest, like removing from the nose.
Yes. Very correct. Sir.
In fact, we should not consider only foreign body as a reason for doing a bronchoscopy. In our whole studies, we have that they form only 18% of the bronchoscopies that we perform in about 1,000 bronchoscopies. So basically, you can even do a bronchoscopy for a lot of other things apart from a foreign body.
Yes, sir.
So I think
We'll
we should
come to that.
always
Yes.
don't just think of a foreign
Yes.
body when you're going inside.
Yes.
When you remove a mucus plug,
Yes.
automatically
Yes.
a pneumonia will clear up. A LRTI would clear up.
Yes.
You diagnose so many conditions in the larynx.
Yes.
So just don't go inside with a foreign body. If you
Okay.
don't get a foreign body,
Yes, sir.
still you can improve the child considerably.
Yes, yes. We'll come to that point. So this is another. When do you suspect that a child have a foreign body in tracheobronchial tree? So these are some of the list. So if anything, choking spells, just we had discussed actually, recurrent bouts of cough, parent's role, some part of toy is missing. So these are some of the conditions which can help you for suspicion of foreign body. This is just, anybody wants to add anything about this? Anything?
Sir, recurrent pneumonias.
Okay, recurrent, yes.
Failure to thrive.
Yes, enable to that. Shyam, sir?
Unilateral wheeze.
Okay, sir.
Unilateral unexplained
Yes.
wheeze is
Yes.
one of the causes.
Yes. Sir?
I would consider a foreign body, even if the X-ray chest is normal, even if a CT scan is normal,
Very true, sir.
even if a MRI is normal,
Yes.
even if a virtual bronchoscopy is normal.
Yes, sir.
So basically, foreign body will be in the back of my mind, and I would do a bronchoscopy for any child, even as an investigation.
Yes.
Nowadays, I prefer flexible bronchoscopy.
Yes.
If for diagnosing the because that we can do it with the local anesthesia.
Yes, sir.
We
Yes,
don't need to really succumb them for
Yes, sir.
general anesthesia,
Yes, sir.
which is definitely a risk factor.
Yes, sir.
So flexible bronchoscopy for diagnosing
Yes.
is a better
Yes.
option.
Later on, we will come to the therapeutic role also in the later part of this, sir. Okay. Okay. Next, we'll go to the next part. Investigations of a suspected foreign body in airway. So, as you agree with me, careful examination, auscultation, tracheal third. But as Divya Prabhat sir told, even if everything is normal, then also we can suspect the foreign body. So, this is some of the investigation battery. Sir wants to add. Shyam sir?
One more investigation, as Purohit sir told, it is a flexible bronchoscopy.
Yes, definitely. That can be.
I will add on to Somani sir. Bronchoscopy is investigation of choice for foreign body bronchus.
Definitely. That itself is
Suspect
investigation.
That is what sir said.
Yes.
If
Yes.
flexible is not available,
Parmanand?
there is no harm going in with rigid.
Same, sir.
Yes, okay. So as we are aware, as Divya Prabhat sir told, there can be a normal X-ray. So these are the some of the X-ray findings which we may get. We may get or we may not get. So we'll go to the next slide. Different types of foreign bodies, like this is a different type, like groundnut, peanut. This is very commonly seen. Coconut piece, almond piece, tamarind. So amongst this, what panel thinks to be more common in their practice? We'll start with Amol. What you feel? Very common. Yes.
As we know, in vegetative foreign bodies in our area, groundnut
Yes.
is and peanuts
Yes.
and all things they are common.
yes. Okay.
Many times seasonal, like custard apple,
Custard apple,
or chiku
yes.
seeds and all. Sometimes even metallic small pieces,
Yes. Okay.
screws, and even
Yes.
Metal balls.
Yes,
pins,
we'll come to
buttons,
that later on.
missiles
Just
and
this
all.
is a common foreign bodies. We'll
Commonest
just,
is always
yes,
groundnut, peanuts.
Yes, yes.
they are-
Any comments, sir? Yes.
Insects I have removed.
Insects. Okay, that's yes. Okay, okay. We'll go to the next slide. Now, there are certain conditions. When bronchoscopy, we think that, of course, when there is an emergency to do, but there are certain situations when we can think when bronchoscopy is really needed or we can wait. So, what are these situations? What you feel in your clinical scenario? So
if you see a patient and you are suspecting something like laryngotracheobronchitis,
recently
in an
we
age
discussed
group-
this issue on
Yeah,
our group.
yeah.
Yes.
In an age group around 1 year of age, and there is no history of foreign body aspiration, then you should observe the patient for next 12 hours with a shot of IV antibiotic and steroid and nebulization. And if it is a croup, then he is going to respond within 6 to 8 hours.
Yes.
The last thing, high fever with toxic child.
Especially, I want to highlight that point. Very toxic child, high fever.
Secondary pneumonitis in other lung, foreign body is in only one lung.
He's on NIV, ventilator in PICU.
Removing
So
that
in such
foreign body
cases,
is
I
not
think.
going to improve the things
Yes.
totally.
Yes.
But you may be doing more harm by giving the general
Yes, that is
anesthesia.
exactly. Yes. So
One of the advantages here can be doing a fiber optic bronchoscopy, do the suction, come out. If the foreign body is seen, certainly you go
Of
in
course,
there.
yes.
But just for diagnosis, I will not do it in
yes.
toxic child.
Yes. Okay.
Mostly when the CT chest is negative.
Okay. Okay.
There are some relative and absolute contraindications for even flexible and rigid bronchoscopy. Like if rigid bronchoscopy patient is not unstable, his heart even unstable angina, or like his saturation is always going down. If patient is having suppose aortic aneurysm, especially in adults.
We'll
or
come to
even
that. We'll come to
kyphosis
that.
again.
Adult. We are going to yes. So next is this is again very important. OT, preoperative preparation for bronchoscopy, like type of bronchoscope, size, telescopes, quality of forceps, suction, trolley. So anybody want to add upon this, apart from this? Prashant sir? Okay. 2 light source, yes.
At least 2 to 3
Yes.
bronchoscope depending on
Right.
the size.
Yes.
2 forceps of each that will not
Definitely. Yes.
and 2 sections.
Yes. Okay. Yes.
Places where we work,
Mike.
generator.
Of course, there is.
Sir, mostly the things when the bronchoscope, anesthetic and attachment to the bronchoscope, where the adapters of the different sizes is required.
Yes.
That is very important. And most of the time, that lacks.
Yes. Yes. Connector is lacking.
Connector, that is very important.
You should keep a tracheostomy trolley also.
Definitely.
In
That's why, yes.
in suspected cases of subglottic
I think
foreign
we
bodies,
all follow this. I think
I
it should be
infiltrate
always-
initially only before starting
Yes, yes.
starting the case of airway foreign body.
Yes,
And,
sir. Otherwise.
More important than the instrument, I would like a calm, confident, and a capable anesthetist with me.
Of course,
If
that
I have
is
a good
the back.
anesthetist, I will do a bronchoscopy on anything.
That's a key person.
Venturi, if it is
used to anesthetist. Used to anesthetist. You who's doing it with you.
Used to good anesthetist. Used to good
Because
anesthetist.
That you can
we've,
say because you
we've
cannot
had
take.
situations where I've been removing a foreign body and the saturation in front of me from 95 has come down to 0. My heart stopped. But the anesthetist told me there is no brady, there is no CO2 retention, you continue. And I removed the foreign body and within, you can say 60 seconds, that 0 saturation has become 100.
Right.
So, I mean, I would give most importance to an anesthetist in such a situation.
I think this is the only emergency surgery in all medical profession where same pathway is utilized by anesthetist and ENT surgeon. That may be the
In
reason.
our setup, pediatrician is also there, ENT surgeon and anesthetist.
It is always
all
there.
three.
Neurologist should be there, and what we
All
say,
three.
that even the pulse oximeter, generally the which
Pulse
where
oximeter we
use,
keep.
Yes.
No, we should have a pediatric probe.
Probe, yeah.
This is very important because these days sometimes they
Yes, sir.
slip off and they don't misguide us.
Yes.
in critical situations, Venturi is very important.
Yes. It also
should be
works. Yes. we use
there.
it. Okay. Right. Okay. Again, just we had discussed about anesthesia as we used to anesthetist, and so which type of different techniques we use, I mean, like continuous insufflation method, intermittent, Venturi, just we discuss. So anybody wants to add here anything in regarding preparation anesthesia?
Basically, when we do an examination of the airway, we don't give any anesthesia. We do it with a flexible. If you want to do it with a telescope, then sedation is given along with high oxygen by the nasal prongs.
Right.
If you want to do a regular bronchoscopy, it is oxygen insufflation which is done, and titration of sedation is done either with Dexmed,
Right.
midazolam,
Right.
ketamine, or propofol. And at the same time, if you want to do a BAL or you want to do a foreign body which is quite impacted,
Right.
at that time you may require either scoline or atra.
Yes. Intraop problems during anesthesia. So I think we'll skip this slide. We'll go to the next slide. Then another important point, use of optical forceps. So importance and when to be used. Sanjay?
So I use only optical forceps. I do have all these basic forceps also, but definitely it has we get a magnified view, and everything is under vision. You can suction, and also in optical forceps you
Any
should have. There are
specific advantage do you feel of optical forceps?
Yes, there are many advantages.
Yes.
There is, I think there is no disadvantage at all. Only disadvantage is less than 8-month child.
Yes.
It's difficult.
That is the
because
only disadvantage.
More than 8 months, I always and since
always
when I
better to have
bought this
optical.
optical
Yes.
forceps, I have not used this regular conventional scopes. And you should have more than one optical, means hard foreign body forceps, soft forceps, and they are costly but
Yes.
worth
On the
buying.
optical forceps, I have realized if we are using in a very old impacted foreign body, I find a little difficulty in suctioning the thing because every time you have to remove the forceps with the telescope.
That is
and,
one more, yes.
Change over the.
Again, there is
light
a disturbance
source.
to the anesthesia also. When you remove the scope,
Change
that's a
over the
problem.
light source
Yes.
because
Yes.
you are, when you put the optical forceps, your light is connected to the telescope.
Yes,
But
sir.
when you need to do a suction, you have to
Yes.
remove it every
Yes.
time, put the cable to the.
There is a
bronchoscope. It takes a little problem.
fluox adapter is
Fluox,
there
yes.
that we can, that is also known as
It is
sliding
Especially
adapter.
Solon foreign
So
bodies
we
like
can-
tamarind
Old
seed,
foreign
that is a
bodies,
classical.
I find a little difficulty with this.
That is very common.
In all impacted foreign bodies, optical forceps will be far, suppose tamarind seed.
That is
Tamarind
classical.
seed,
Tamarind seed is very
will be very difficult because
Very
you
difficult,
need
really
tamarind
difficult.
seed, you need stars
You need
forceps.
optical.
And even stars forceps, you need at least 4 types of forceps pilot opening, which can take a piece of a tamarind piece and you have to remove almost 8 to 10 pieces. Then only the tamarind seed will come out, because if tamarind patient is history of taking in injection of tamarind seed more than 3 days,
Swollen.
the size will be quite big, and unless you have to go for tracheostomy, then previously we used to do regularly tracheostomy
Yes.
for removing
Because
tamarind
it doesn't
seed.
come out to
But
the vocal
nowadays,
cords. That
because
happens.
with routine Indian forceps, we cannot get grafts
Very
of
difficult.
tamarind seed.
Absolutely,
So I
absolutely.
think that's why
Yes.
imported like
Okay.
German scopes, they are better.
Yes, okay. We'll go to next slide. Actually, this is a small video I just prepared. Actually, I shared with Divya Prabhat sir also and with Amol also. This is a recently Actually, this is a telescopic foreign body. Opening. So just I will go through it very. This was that scarf pin, burqa pin. Actually, we have discussed about this. Dr. Amol also we have discussed. This is actually limitation of our scopy, bronchoscopy. We are able to see the burqa pin at the, see, very classically seen here. You can clearly see this. This was in such a distal peripheral part, forceps couldn't reach. So, for this we actually used magnetic forceps. We'll discuss it later on. Just a situation I just want to elaborate. Now next is which foreign body is difficult to remove and which foreign body is problematic with patient. Just Amol.
Subglottic
So
impacted
this
foreign
glass
bodies.
bead.
Tamarind seed is
Tamarind
always
seed,
more
yes.
difficult.
And
If,
this,
if there is a history of more than
Yes.
36 hours,
Then
I think it is
then
it swells.
dangerous, yes. Dangerous foreign bodies, safety pin and this burqa pin or scarf pin. I just shown that video before that. So these are again very dangerous, very difficult and can be problematic for the patient. Of
Open,
course,
if there is open safety pin and the upper end open end is down,
You have to get.
there is no way you are going
Yes.
to remove it.
Yes.
You have to go for bronchotomy and we have
Yes,
removed,
yes. Otherwise, there is a
because
tear.
we have removed
Yes, yes.
4 to 5 cases
Yes, yes.
in last 32 years
Yes.
by open bronchotomy.
Yes, yes.
And since we are having all facility for thoracic surgeon and all these things,
Yes.
and even doing, because I was assisting him, thoracic surgeon,
Yes.
and even when we opened the bronchus, it was very difficult to, I have to cut the pin and again there was lot of oozing and bleeding.
Yes, so these are the
And
difficult.
Again open bronchotomy,
Yes.
these cases are very,
Yes,
very difficult.
just I want to highlight here this, just I mentioned about role of magnetic forceps. 2 foreign bodies recently I removed with this magnetic. It is very easy and they use just Dr. Somani sir was telling fiber optic. This is one of the I think only indication where fiber optic bronchoscopy is used for therapeutic purpose, where you put it and then put that magnetic forceps is very malleable and then you just touch it and it comes out. 2 cases recently. So I think this is one of the indication of fiber optic bronchoscopy, therapeutic indication. Okay.
Many
So
chest
these are all.
physicians, they are removing small
Of
foreign
course,
bodies
of
with
course.
fiber optic.
I
but
learned-
in pediatric patients, foreign bodies,
Yes.
it is very difficult.
Yes.
You have to go for rigid because even
But
in
these
pediatric,
these patients are classically 13-14 year females. They are not.
So
So
they're-
this is
they're
the typical that pin that is classical patient. Adults. Yes, we have got 3-4 cases discussed.
Yeah,
So
even in adults, I mean, because all of us treat adults also, when they find a foreign body, they send it to us. Nikal ke do hai.
yes. Again, important questionnaire. How much time you should to take for bronchoscopy? This is very, very important. So panelists would like to discuss this point. How much time for bronchoscopy? Is there any?
There is no, I think, because one of our patient had, 2 of our patients had cardiac arrest during surgery. So we, whatever DC cardioversion and everything given to the patient, and later on we took the patient immediately. Because the foreign body, the patient was not at all maintaining the saturation. Time, regarding time, in our, at least in my series, almost in all cases I was successful to remove the foreign body, but exact time you can't say. It depends on the status of the patient.
There are
and
certain
anesthetic.
conditions which make you to limit your bronchoscopy. Means intraoperative condition, anesthetic problems, foreign body problems, technical. So that is what I want to ask you. What is
Technical problem is if your forceps are not working.
Of course, these
then
are
you have to.
Otherwise, okay. So, but you cannot continue the bronchoscopy for hours. No, it's a procedure of minutes maximally. This is what I want to highlight. What is your opinion?
I beg to differ here. I have done many times for bronchoscopies for 40-45 minutes.
Okay.
My anesthetist has never said that patient is compromised.
Okay.
Sometimes, few times when the bronchoscopy was abandoned, it was on my behalf.
Okay.
I was finding it difficult, the foreign body was not coming out. Okay. Otherwise, we should remember one thing, that this is a normal child who had accidental investigation of ingestion of a foreign body. There is no other pathology. His other lung is very good.
Yes. So as long as you remove the foreign body, you should continue.
Especially in tamarind seed, if it is a long duration, patient is having long
sitting is
long
sometimes
standing session, and your bronchoscopy time goes beyond 50 minutes, what will happen?
False
False cord, vocal cord, and edema will
Yes.
start
That-
even after giving very
that
high
point
dose
I
of
want to
steroid.
discuss. Key,
So
what
if
you
you are
feel.
not able to remove, normally anesthesia
do
will
it.
take 5 to
Yes.
10 minutes. Your job will be 5 to 10
Yes,
minutes. And
that's what I'm saying.
Chexoscopy and all
Only
will
problem
be
is
very
the
fast.
old long
If it is
standing
not
foreign
coming,
body.
you
And
have
long-standing foreign body.
If you are not able to remove.
infected chest, old long standing foreign
So,
body.
compromise.
There-
Clarify my position.
Sometimes,
If the surgeon is not able to remove the foreign body because of some difficulty,
When you should stop either.
then he should stop,
Rather,
come back
that is what
again
I'm
after
saying.
2 to
You should
3
know your
days of
limitation
examination
also.
and all.
That is
what happens is the child saturation is already low. They are referred from some NICUs,
Yes.
ICUs.
Already he is
In
compromised.
that case, already sometimes anesthetist suggests that now
Yes.
the saturation I'm not able to maintain.
Yes.
Where you need to stop because otherwise it
Sometimes the bachchu come with 10% saturations to us.
Many times
Saturation.
now you face sometimes very difficult. I will just tell you, there is a supari, very, very long standing foreign body. I catched it with Storr forceps and it was so stuck that when I catch with the forceps, it is not coming, the scope is not mobile. And I am not able to, I try to pull it out. You used good amount of force, but still for 2 to 3 minutes, I was not able to. I was knowing that I catch the force, but it is so stuck that it was not able to come. So it was very difficult
So
thing.
these are difficult
Saturation was going
situations.
down. Then
Yes.
I have to just. I did not do anything. I tried to rotate the forceps, put some 4% halogen, and for the God sake, because again.
So you have to take a
pray in such
proper
conditions.
decision in
And
certain these
fortunately,
situations.
It came and it came with along with the foreign body.
Good, yes.
So again, such things happen. They happens very rarely.
Very,
It
yes.
happened with me only 2 times in
Yes,
32
yes.
years. So I think
Okay.
it is.
But when you leave the child in with the foreign body as it is, it should be a safe outcome.
Absolutely.
Otherwise,
Yes.
a patient comes out of anesthesia and if you need ventilation and other issues, then it is a problem.
Yes.
The best way is wherever the foreign body you are not removing because of bleeding, granulations or some or other issues or ventilation problems. See to it the foreign body lies in the same
Stable.
area
It is stable.
or same
Patient should
lung.
be stable. Foreign body is stable and patient is also stable. That you should
then
have to assure.
you
can
should
try it
come
af-
out.
after
It's
few
a
days
safe
or again.
escape
Yes.
then.
Yes, safe escape. Right.
should be no bleeding.
No bleeding, absolutely, yes, because, okay. I think we discussed this. There are certain situations like Dr. Amol just, certain cases you have to abandon. Just we have discussed, I think we'll go to the next slide. Role of tracheostomy, I think we have discussed. There are certain situations. Anybody wants to highlight this?
Previously, 30, even for tamarind seed, we used to go for tracheostomy, but nowadays, when we got
Almost-
Storr forceps and Storr
Though we
scopes,
keep a tracheostomy ready, absolutely now
tracheostomy-
we don't need anything.
tracheostomy tray should
Yes.
be ready.
Tracheostomy ready and consent ready.
Consent,
Consent of
course.
tracheostomy.
Yes, yes. So coming to
Some
the...
of adult I have removed because I have, my adult series also long. I have
Yes.
removed
Yeah, I'm
a
coming
third
to that.
molar
I'm
and
coming.
so
I'm coming.
even with the tracheostomy, it was very difficult to remove
Yes,
through
yes.
tracheostomy.
I'm coming to that, Amol.
Sir.
I'm coming to that.
as the time instrumentation anesthesia is improving, we are doing less and less tracheostomies for
Absolutely,
foreign body.
yes.
But every surgeon in his mind should keep it in mind that this is one way out, and we should not forget.
Yes, it should be kept in
Whenever
mind as well
yes,
as
it should
physically
always be
also
kept in mind.
tracheostomy should be there, ready.
Yes, yes. Yes, and you
Of
should
course.
have think
Yes.
that
Anything,
thinking
anything,
in the
yes,
mind also.
definitely.
because this foreign
It
body
can
may
go
be
that way
delivered
also.
from that.
Laryngeal foreign bodies after removal, patient may come with a severe stridor.
Yes, edema,
So
like
that is one more situation where one should
You may go
keep
for it.
it.
Yes, sir, absolutely, yes, yes. We'll go to, now coming to this some adult foreign bodies. Dr. Amol, to highlight.
These are all my patients, and
These are your picks
these
only.
are all iatrogenic foreign bodies. One new ICU, one intensivist patient has a AMI, and he put one teeth. Normally,
I think this
denture
was
will go
a
in
30-year
the-
stay,
the-
na? This
the
is
second
30-year
patient.
stay. This pin was 30-year stay in your case?
No, this patient is actually
Very unusual.
He
actually.
was a total laryngectomy done, and he was using a brush there,
Yes.
and accidentally he put it. So I thought I was having I will just grab it blindly with the tracheostomy with a long artery forceps, and I tried 3-4 times. I could not. Then I used flexible bronchoscope.
So in-
this is very rare foreign body in the first case, the old man, which I have removed with the flexible.
So such types of foreign
The
bodies,
second case is, I think, again, one
Denture,
intensivist did
aspirated.
intubate patient, and he put 3 teeth in the bronchus. So again, 2 were able to remove. The one teeth was far beyond my rigid. So again, this patient was having COPD and all these things. So patient has to kept in ICU and that patient succumb after.
So
10
we
days
do
because
come across adults.
he was
foreign
not
bodies.
fit for open bronch.
Okay, right.
Doing rigid bronchoscopy through tracheostomy is easy in adults.
Yes, I agree with you.
Many times we remove blood clots and all because even organized clots,
Because
they are very difficult to remove with the flexible.
distance is reduced
and
and
we
we
have to
get
go for
early
rigid
bypass.
bronchoscopy.
Okay, we'll go to the next. Routine post-op care I'll skip because of the lack of time. I will also skip this question. Advice bronchoscopy where PICU setup not available. Anybody wants to answer
After
this?
removal of foreign body, every
Yes,
patient
yes.
has to be put
Yes.
on
I think
adrenaline,
panel will
Budocard
agree with this.
nebulization with Deolin, and
it
it is
a
again
must. It is a must. Yes, yes. Okay. Post-op complications. Now I will come to this important thing. Learning curve. Nice. For the young budding bronchoscopists, I think this should be done for the young budding. This teaching, like Dr. Sanjay is doing, Dr. Divya Prabhat sir is doing. Sir, module should be prepared, and that should be like this. Dr. Sanjay is doing a lot of work, and many people are trying. So I think training these our residents, PGs is very, very important. We should assure them, we should teach them, and then only they can get away from the fear of bronchoscopy. Anybody, Divya Prabhat sir, you want to add?
As far as teaching is concerned, I feel very happy that 30 years ago, when one of our panelists was there with me, I mean, he rang me up. I've done my first foreign body bronchus removal. He was at Vadia with us. Yes. Then I got a call that I have removed 1,000 foreign bodies.
Yeah,
then after some time, I got a call that I have removed 3,000 foreign bodies. That's Dr. Ramesh. So we...
Congrats.
Thank you, sir. Thank you for the kind words.
So we do training, and in practically all cities, including Sholapur, we have our fellows who have trained and are doing bronchoscopy in practically most of the big cities in Maharashtra. The other way what we do is, instead of working as a resident, I mean obviously it should not be because that involves a lot of time, we have 2 days workshops where we teach on 3 different modules. One is a fiber module where we teach a bronchoscopy to our colleagues. Second is we use a goat, the head removed, and we put foreign bodies inside, and with a rigid bronchoscope remove foreign bodies on goat. And third, we have a computerized animated simulator. On that you can use a fiber optic to guide how you guide into the bronchus.
So in short, training is
we
essential,
have training programs for 2 days for bronchoscopy, and we have residency for 6 months for bronchoscopy. So these are the 2 methods
Yes.
how we are teaching.
Yes, sir.
We are doing for our residents a live experience. If the child comes with the foreign body bronchus, I do the scopy, check it, remove it, and recheck it. Once that is done, everything is stable, anesthetist is happy, I am happy, then the resident comes in. I request anesthetist for one more or a small dose of scoline, and then he does it in front of me, guided by me. So this is the hands-on experience for them also, without compromising anything on the patient.
One more thing to add, just we always should do a check bronchoscopy afterwards.
Absolutely,
which we
yes,
mentioned,
yes,
we
sir.
forgot, because
Check scopy
I
should-
myself has come across
Absolutely,
where I
sir.
have removed
Check scopy is essential.
one foreign body, I was happy, and just we did a check scopy, we found two
Especially
more
this is
inside.
very true about the groundnut, sir.
Two
Groundnut, if
inside.
one part is remaining,
So
second part should
we
be
have
checked.
to get
Yes, sir. Absolutely
check
right.
scopy to
Yes,
be
sir.
done.
Yes, sir. Yes, yes.
In all cases, check scope.
Absolutely, yes.
As a rule.
Yes.
Repeated auscultation is also important.
Yes. So, panelists, as you all agree with me, after doing a lot of this stressful job, then if this, we get such a smooth, just a end part of this, one of the custard apple seed. So, we feel blessed and happy and very good. So, with this, I will like to conclude the session. Thank you very much. Thank you all panelists. Thank you all. Thank you so much. Thank you. Thank you. Questions, sorry. Questions, any questions from PGs and all these things?
One just thing I have to add, because everyone's saying you should keep you should have a ICU, PICU ready.
Yes.
I, Dr. Somani, sir, we practice at our own places
Yes,
where
sir.
we don't have this facility.
Yes, sir.
But what we do is, suppose we have a patient who is bad, we always call intensivist to
Of course.
stand by, because For juniors who don't, they are not attached to any big hospitals,
Yes.
can also do it.
Definitely,
This is
sir.
my advice.
Yes.
And we keep some neonatologist along with we keep one ambulance ready outside, and I have shifted patient immediately to his places. So it is not mandatory that you should be attached to any big hospital to do it, because in small areas, places, we
Very
have
difficult.
to do
Yes,
it at
practically
office.
difficult.
Yes,
Yes.
I just want to pass a message
Yes,
to
sir.
you.
Yes, sir.
Practical advantage of this is.
Yes.
Yes.
With the availability of so many number of doctors now, whether the incidence of long-standing foreign body has reduced and awareness.
I think we have discussed that point. Ki, I think
We still are removing foreign
we
bodies.
still get
after
some
one
answer is
year,
yes.
We still
9
get.
months.
Answer is yes.
As we discussed, now, pediatricians are the key role who refer the patient to us. No? So until they refer,
Don't get the history, so they go on a wrong track on.
And there was one more question regarding consent. So in all cases, we take death on table consent. In
Not
at
on
least-
date on. Nowadays, if you see my
On
mobile, I have sat in front of the patient's relatives. I
And
have
video consent.
recording
Audio,
it,
visual,
because
video,
one
video
patient,
consent.
one case I am still facing. They have already mentioned that you have taken a consent on a blank. They later on they say all change.
It's always better
we
to have a
record
proper consent.
this
Yes.
Sitting in front of us,
Yes.
I make them sign in front of me.
Yes, medical legal problems arise because itself is a medical legal. It's a MLC. Any foreign body we treat as a medical legal.
No,
So I
but
think
the consent and severity of the consent
Should
should
be
depend on
informed.
the patient's condition
Yes.
and site of lodgement.
Definitely.
If there is a tracheal foreign body or laryngeal foreign body with impending hypoxia, convulsions,
Low saturation.
and then you need to take a consent which is very severe type of, or patient may die or all. But for bronchial foreign bodies, you don't have to go to that extent for removal.
But even bronchial foreign bodies, you have to tell that 99% it will come and 1% there is a risk.
Yes,
to-
of course.
1% is always a risk.
You cannot give any 100% guarantee.
We,
Yes, Prashant.
even if in institution, we make it sure that the
Which are
faculty who is removing the foreign body is the one who takes the foreign body. This is a consent which is not to be delegated to anyone.
Yes.
It has to be taken by the surgeon himself.
questions from audience, please. Any questions?
Thank you, sir.
Thank you. Thank you all.
May I request Dr. Divya Prabhat, sir, to felicitate our moderator, Dr. Sunil Deshmukh, sir. Sir, please felicitate moderator. तुम्ही चेअरपर्सनला करता फेलिसिटेट हां नाही आय कार्ड बघ May I request our chairpersons to please felicitate panelists.
Yes, sir. अरे मस्त नंबर ऑफ काय सर मी येतो 23ला भेटायला तुम्हाला घरी माझी पोरीची परीक्षा प्रॅक्टिकल येतो भेटायला तुम्हाला येतो सगळं Yes.
I request Dr. Praveen Bhosle, sir, to felicitate our chairpersons. Dr. Pushkar Lele, sir. Stage. Dr. Rajendra Akul, sir, and Dr. Chaitali Zambre, ma'am.